Hi, this is Nicholas Hatcher, and in this lecture we will discuss the management of patients requiring invasive respiratory procedures. The objectives for this lecture include the following. Analyze the indications for intubation. Describe what is needed to prepare for intubation. Discuss the monitoring of the patient during intubation. Describe the management of the patient following intubation. Discuss the indications, preparation, and management of the patient requiring thoracentesis, and briefly describe bronchoscopy. To begin, let's briefly review the oxygen delivery trajectory. We always try to begin with a simple nasal cannula. We would then move to a face mask, and then attempt a non-rebreather. Next, we would try our non-invasive positive pressure ventilation methods, including high-flow nasal cannula, CPAP, and BiPAP. When these mechanisms fail or are inappropriate to the situation, intubation is required. Intubation can be a very difficult experience for the patient and the family. Adequate understanding and preparation for the procedure will help this process run much more smoothly. Intubation is indicated with severe apnea, airway obstruction, for airway protection, for instance with severe altered mental status, respiratory insufficiency or failure, hemodynamic instability, and may be associated with the projected clinical course. The P's of rapid sequence intubation can assist in remembering the steps of intubation. These include preparation, pre-oxygenation, procedure, proof of placement, and post-intubation management. Preparation is the most important step for intubation. This step is especially important for the bedside nurse in order to ensure a well-structured procedure. A useful mnemonic for recalling the steps of preparation is I-SOAP-ME. This stands for informed consent, suction, oxygen, airway equipment, pharmacological agents, monitors, and end-tidal CO2 or EtCO2. There are a variety of suction tools available for use. The one on the left is a Yonker, and the one on the right is a deep suction catheter. You want to ensure that you have a working oxygen supply as well as a bag valve mask available at the bedside. Endotracheal tubes come in a variety of sizes. It's important to check with the proceduralist to determine the size or sizes needed. Always ensure that multiple endotracheal tubes are available during the procedure. The endotracheal tube has a balloon next to the tip called a cuff that is inflated with air. The balloon is inflated with a 10 milliliter syringe attached to a one-way valve on the pilot balloon. This is shown here as a small blue balloon. Another tool that needs to be available for the procedure is the laryngoscope. There are three common types of laryngoscopes available. In the top left corner is a Macintosh blade. Below the Macintosh blade is the Miller blade. Below the Miller blade is the McGrath laryngoscope. The McGrath laryngoscope has a small display that will allow the proceduralist to visualize the airway. With the Macintosh and Miller blade, the proceduralist must look in the airway using the light source at the tip of the blade. Another tool that is needed for intubation is a stylet. The standard stylet is placed in the endotracheal tube and is pliable to assist with maneuvering the endotracheal tube into the trachea. The bougie is a great tool for intubations with a poor visual field. The bougie is inserted into the trachea and then moved back and forth. The proceduralist can then feel the clicks of the tracheal rings as he or she moves the bougie. The endotracheal tube can then be placed over the bougie and into the airway. Artificial airways can help maintain an open airway. The two types of artificial airways include the Nasopharyngeal and Oropharyngeal Airway. To determine the appropriate size for the Nasopharyngeal Airway, measure from the nose to the tip of the mandible. The NPA is then lubricated and then inserted beveled edge against the nasal septum. This may stimulate the gag reflex if it is too large. To determine the size of the oropharyngeal airway, measure from the corner of the mouth to the angle of the mandible. When placing the OPA, depress the tongue with a tongue blade or Yonker and insert over the tongue. There's a risk for vomiting if the gag reflex is intact, and these may occlude the airway if they're too large. You will need equipment to secure the endotracheal tube once it's been placed. There are several methods available for securing an airway. The availability of equipment will vary with institutions. Simply taping the airway in place is common. Note that if the endotracheal tube is taped to one side of the mouth, it should be moved at least once daily or per hospital policy in order to prevent skin breakdown at the corners of the mouth. Finally, a towel should be available for pediatric and obese patients. Placing a towel under the shoulders can help align the airway for better visualization of anatomy. The pharmacological agents used during intubation will depend on the procedure list. I've listed some of the commonly used pharmacological agents for inducing analgesia, sedation, and paralysis, as well as a few additional agents that may be used. These are often administered by a CRNA, anesthesiologist, or the proceduralist. Monitoring equipment that should be available during the procedure include pulse oximetry, telemetry, and a blood pressure cuff. The blood pressure should be recycled every 5 minutes during the procedure. Telemetry should be monitored for any arrhythmia that may compromise the patient, and pulse oximetry should be monitored for desaturation. There are two different ways to monitor end-tidal CO2. The first is a CO2 detector. This allows for a spot check and hooks to the endotracheal tube. Once a breath is delivered through an ambu bag, the CO2 detector should turn yellow on exhalation. Yellow means that the endotracheal tube is in the airway. The second form of monitoring end-tidal CO2 is by waveform. This evaluates the ventilatory state and lung perfusion, and correlates well with the PaCO2. End-tidal CO2 will increase before the SaO2, or oxygen saturation, decreases. Normally, the end-tidal CO2 ranges from 35 to 45, just like a normal PaCO2. End-tidal CO2 can be increased when there's a decreased respiratory rate, hyperthermia, or partial or complete airway obstruction. The end-tidal CO2 can be decreased when there's an increased respiratory rate, decreased lung perfusion, for example with shock, pulmonary embolism, or cardiac arrest, hypothermia, a partial airway obstruction, or leakage of exhaled gas. It's also important to have the right individuals at the bedside for intubation. This includes a respiratory therapist, a patient monitor, a procedure assistant, and of course the proceduralist. Pre-oxygenation is an important step just prior to intubation. If possible, the patient should be oxygenated with 100% O2 through a non-rebreather for 3 to 5 minutes to provide nitrogen washout. Clearing the lungs of nitrogen in this instance will allow more room for oxygen. This will prevent harmful desaturation during the intubation procedure. Some studies have supported the use of the non-rebreather method paired with 15 liters per nasal cannula. During intubation, the nurse's primary role involves monitoring the patient and handing the proceduralist necessary equipment. The proceduralist will insert the laryngoscope into the oropharynx and search for the vocal cords. The endotracheal tube is then passed through the vocal cords and into the trachea. On the right is an image of the anatomy, as well as a realistic view of the vocal cords. There is conflicting data on the use of cricoid pressure during intubation. Hypothetically, holding cricoid pressure will prevent reflux of gastric contents during the intubation procedure. An alternative to endotracheal intubation is cricoidotomy. This may be considered with severe facial trauma or an upper airway tumor or edema. The proceduralist will make an incision over the cricoid membrane and insert an airway through the incision site. Another method of maintaining an airway is tracheotomy with the insertion of a tracheostomy tube. A tracheotomy is used to bypass upper airway obstruction, to allow removal of secretions, to permit long-term mechanical ventilation, to prevent aspiration of oral or gastric secretions in the unconscious or paralyzed patient, and to replace an endotracheal tube. An incision is made over the trachea and tissue, and the thyroid is dissected. Another incision is made through the second, third, and fourth tracheal rings. The tracheostomy is then inserted into the incision site and supported with a securement device. After intubation, it's important to ensure appropriate placement of the endotracheal tube. This is done by checking the end-tidal CO2, auscultating for bilateral breath sounds, observing symmetrical chest wall movement, and obtaining a chest X-ray. There are several components of post-intubation management, some of which include checking the cuff pressure every 6 to 8 hours, monitoring for signs and symptoms of aspiration, ensuring a high degree of humidity, which can be noted as moisture in the T-piece, administration of oxygen as prescribed, securing the tubing with tape, suctioning as needed, turning the patient every 2 hours, and oral care. Monitoring cuff pressure, maintaining humidity, and titrating ventilator settings all fall within the scope of practice of the respiratory therapist, although in some areas, the RN is primarily responsible for these tasks. Just to give you an idea of appropriate placement of an endotracheal tube, here we have the right lung, over here's the left lung, this is the heart, here's the trachea, and right at the base we have the carina. This is the right mainstem bronchus, and then the left mainstem bronchus moves this way. Most modern endotracheal tubes have a radio-opaque line moving across them. So here's the line moving down, and in this case it's sitting between the clavicles. Endotracheal tubes should be 2 to 3 centimeters above the carina. This one's about 5 to 6 centimeters above the carina, which is appropriate position. Now we will discuss thoracentesis. Thoracentesis is indicated for the diagnosis of pleural effusion etiology. There are two main types that we're looking at. A transudate is a product of imbalanced hydrostatic pressures, and an exudate is a product of increased capillary permeability or lymphatic obstruction. You will get more information on this condition from the lower respiratory tract disease lecture in Chapter 23 of your medical surgical textbook. A thoracentesis can also be done for the therapeutic reduction of respiratory distress in patients with large pleural effusions. Thoracentesis is contraindicated in or should be approached with caution in patients with a PT or PTT greater than 1.5 times the upper limit of normal, in situations where they may be on anticoagulant therapy, have an underlying coagulopathy, or thrombocytopenia. It should also be done cautiously in the patient on the mechanical ventilator and those with severe hemodynamic compromise. This image is a little fuzzy, but it shows you what a typical thoracentesis kit looks like. This is the thoracentesis needle with a stopcock on it. Here are some needles for anesthesia. Here are a couple of vials of lidocaine. Here's a small scalpel to make incisions. These are some tubes to collect samples. And over here are the fluid collection bags. Here's a list of the equipment in the thoracentesis kit, as well as other items that you may need. In preparing for a thoracentesis, you'll want to explain the procedure to the patient and ensure that all questions are answered. Obtain informed consent and perform a timeout, ensuring that you have the right patient, right procedure, and the right needle insertion site. This procedure requires a two-person assist. One positions the patient, and one fills the evacuated container and specimen tubes. For this procedure, you'll want to place the patient in a sitting position on the edge of the bed, leaning forward with arms resting on the bedside table. Alternatively, the lateral recumbent or supine position can be used if unable to sit. For the procedure, the provider will use ultrasound to determine the location of the pleural effusion. The site will be marked, then anesthetized. The provider will then insert the needle and attach the stopcock or tubing, and then aspirate fluid. Here's an image showing the needle going into the pleural cavity. The RN's role in this procedure is to ensure patient safety through timeout and obtaining informed consent, ensuring sterility through hand washing and appropriate cleansing of the site, ensuring that the patient maintains a proper position, assisting to fill collection tubes, and monitoring the patient for potential complications. Potential complications of thoracentesis include the following: pneumothorax, pain and coughing, localized infection, hemothorax, intra-abdominal organ injury, air embolism, and post-expansion pulmonary edema. The last topic we will discuss is bronchoscopy. Bronchoscopy is an endoscopic procedure that visualizes the tracheobronchial tree by placing a bronchoscope into the airway. There are two different groups of indications for bronchoscopy: diagnostic and therapeutic. Diagnostic indications include the evaluation of pneumonia or infiltrates, persistent atelectasis, lung masses or nodules, hemoptysis, suspected airway obstruction, toxic inhalation or burn injuries, and chest trauma. Therapeutic indications include mucus impactions, foreign body removal, endotracheal tube placement, tracheobronchial stent placement, and treatment of emphysema. Bronchoscopy is done in the operating room, intensive care unit, or emergency department. The patient is sedated, the airway is inspected, and the procedure is performed. Complications of bronchoscopy include bleeding, pneumothorax, cardiac arrhythmias, and hypoxemia. Because of these potential complications, it's important to have a chest tube tray, airway equipment, and cardiac monitoring available. The PTT and INR should be checked prior to the beginning of the procedure. Bronchoscopy is contraindicated in the patient at risk for cardiopulmonary decompensation and those at high risk for bleeding. Just so you're aware, none of these procedures are within the scope of practice of registered nurses. However, if they really interest you, consider becoming an acute care nurse practitioner once you've survived nursing school.